Hello, this is the final Parkinson's video, part 3. And so you know that what we did with this lecture about Parkinson's is we took it and tried to teach you the clinical judgment model as we lectured on the different parts. So the first two parts of the clinical judgment model are recognize cues, analyze cues. We did all of that with signs and symptoms and risk factors and different things like that in the first video, part 1, Parkinson's. And then we moved on to part 2, Parkinson's. And in part 2 of Parkinson's, we talked about the third and the fourth step in the clinical judgment model. And the third step in the clinical judgment model is prioritize hypothesis. So what you saw me do in the part 2 of Parkinson's was I compared Parkinson's and contrasted Parkinson's with multiple sclerosis, myasthenia gravis, ALS, Guillain-Barré, Huntington's disease, because what you're doing when you think about prioritizing hypothesis, you and I both know that several diseases mimic each other. And we told you in part 2 of Parkinson's that it's like taking a patient who comes in with a runny nose and a cough and a sore throat, runny nose, cough and sore throat, or like just upper respiratory kind of crap going on. And you're trying to figure out, okay, let's make sure the patient doesn't have a cold versus a flu versus pneumonia versus sepsis or whatever else. And so now we're at part 3. Oh, sorry. In part 2, we did the whole prioritize hypothesis. So I showed you that. And then we also did number 4, the fourth step of the clinical judgment model, which was literally generate solutions. And generate solutions is hard. I think it's the hardest part of the clinical judgment model because generate solutions is all about the plan of care, and it also includes the number 1 area of failure on NCLEX, which is basic care and comfort. And so I really spent a lot of time teaching you what to do for this patient in part 2 and all the nursing care that you needed to do. This final segment of Parkinson's, this final conclusion of Parkinson's, is going to focus now on the last 2 steps in the clinical judgment model. You may remember, hopefully you do, that the last 2 steps of the clinical judgment model is take action and evaluate outcomes. Now, if you are sitting there with your finger in your nose going, what the fuck is a clinical judgment model and what does it have to do with me? Let me explain for real. The clinical judgment model is what you are judged on, graded on, evaluated on, and scored on when you take an NCLEX exam and they give you a case study. Literally, I have had students, I had this one young lady came into my classroom here, right here, to sign up for my program 2 days after she had failed this new next generation NCLEX exam. She joined my class a couple days after failing. She already had her report from the Board of Nursing, and she showed me that report, and the report looked different from anything I'd ever seen from the old test. And on that report, it showed where they graded you on clinical judgment model. You got a score, not number score, but you got an evaluation of your performance for recognizing cues. You got a score for analyzing the cues. You got a score for prioritizing your hypothesis. You got a score for generating solutions. You got a score for taking action. And you got another score for evaluate outcomes. I was like, OMG. So I need you to know that my new way of improving and revising and redoing and renewing and jamming and jamming and I'm sorry, I get so caught up in music. But my new fangled thing since this test has changed is to make sure that every video that I do from this point on, and Parkinson's is our first experiment with this, that I make sure that I incorporate the 6 steps of the clinical judgment model. And I'm always revising my shit because I'm a perfectionist and your life and tests depend on it. So I just got to hook you up today. So here we go. It's kind of fast because this is short and sweet. Now, taking action in this case, because we already told you about generating solutions and some things you'd have to do for the patient in basic care and comfort. But taking action in this case is going to be to focus on some of these medications, because this patient's disease process, there is no real cure. But if we want to optimize their quality of life, they're definitely going to be on medications. And they're probably going to be on at least 3, probably even 5 medications just for the Parkinson's alone. So let's look at some of those medications. Parkinson's disease meds. That's what the title of this part of the lecture is. We have ropinirole, which is Requip. That's the brand name. You don't give a shit because you got to know the generic name, right? You know the test is all generic. Ropinirole is a dopamine agonist. Now, I don't know if you remember agonist versus antagonist, but agonist means it helps dopamine, or it stimulates dopamine, or it potentiates dopamine. I could do this all day. It feels really good, like breezy and shit, but I'm sorry, I'm trying to teach you some stuff. Okay, so it's a dopamine agonist. It also treats restless leg syndrome. Might need to know that. It decreases the dyskinesias that come from some of the medications that we use for Parkinson's. Now, what the fuck is dyskinesias? Well, it's the involuntary twitching of the mouth, the sticking out of the tongue, facial grimacing, a lot of the weird shit that makes you look like you got a problem. It does decrease that, and this dyskinesias that it works towards decreasing, that comes from some of the Parkinson's meds. So it is what it is. Now, usually we're going to start something like ropinirole. Yeah, I said that shit right. We're going to start that in the early stages of treatment. However, you got to be very careful. While the patient is feeling their way through some of these medications, this is not the medication to pop in your mouth and get in a car. I would advise taking this medication in the evening, late evening at that, because it causes significant drowsiness, like the patient could just be all of a sudden falling asleep in front of you. Okay, so this is a big deal. This is not a day shift medication. Taking it in the evening is probably much more recommended. Now, if you look at number 2, these meds might be very familiar to you. One says amantadine, but another alternative medication, not a different name for the same drug, no. Another alternative medication that does what amantadine does is benz. Why am I acting retarded? Because I don't want you to fuck this name up. I don't want you to say benzotropine. No, because then your little ass is going to get mixed up. Not benzo nothing, because that sounds too close to benzodiazepines. No. This is benzotropine. Did I make myself plain and clear? I hope so. I sound like an idiot. Okay, so benzotropine is an anticholinergic. Let me park right there for the babies. You remember acetylcholine? You remember dopamine? Remember this. Dopamine was low, which made the effects of acetylcholine high. So it makes sense that we would give an anticholinergic to the patient. Now, I don't know if you learn like I do with rhymes and whistles and things. Now, you can't make your whole damn lecture a rhyme and a trick and a mnemonic. That does not teach us. That's just memory that actually gets confused with other mnemonics. No. But I would have to say that this was one of those little rhymes, Jay-Z rhymes, if you will, that stuck with me. And shameless plug, I've been a nurse for almost 40 years. And so this little rhyme has stuck with me since the 80s. So we're just gonna have to share it with you because I think you'll like it. Remember that your anticholinergics have some interesting side effects. let's look at it. Here's a good way to remember it. Can't see, can't spit, can't pee, can't shit. Woo, honey. Now listen, I know that a lot of you people are really good people. I get that. You don't understand why I swear. I get that. I don't give a fuck, but I do get that, because reality is my students know, just like I know, that I learn and remember shit, the more fucked up it is. And so this is fucked up. I'm going to give it to you. It's not medical jargon. It's not pharmaceutical talk. No, but your ass gonna remember. Can't see, can't spit, can't pee, can't shit. Let's do this in a pharmaceutical way, shall we? Blurred vision. So don't go giving this to the patient with glaucoma. Dry mouth. Urinary retention. So this is not the drug for BPH. Your man got an enlarged prostate. He ain't got no business with no anticholinergic medications. Can't shit. Now listen, you know what that is. That's constipation and whatever else you can throw in there with it. What I'm saying to you is this benztropine, just like, get this, atropine, are anticholinergic drugs that have these side effects. So you have to be super careful not to give this to a glaucoma patient, to a BPH, benign prostatic hypertrophy patient, enlarged prostate. If your patient impacted, what the fuck are you doing with this benztropine? Okay, you see where I'm going with that. Okay, now, so be careful also with the elderly, because it can really further impair their cognitive function. So remember how I said more than 50% of people are going to have some cognitive deterioration? This ain't for that patient. This is for the one that ain't got it, okay? Now, why are you taking these medications? Oh, very simple. Not only does it work on the tremors, it also works on the dyskinesias. It also works on the early stages. So these medications can help with the medications that cause dyskinesias, which are a lot of Parkinson's meds. And it can also help just with the baseline uncontrollable movements. Remember what we gave benztropine for in the psych patient, because this is cogentin. Remember what we gave it for, y'all? You remember them EPS symptoms, extrapyramidal symptoms? You might remember dystonia, akathisia, you had your tardive dyskinesia, and then you had something weird called what? Pseudo-Parkinsonism. Isn't this Parkinson's? Remember that psych meds gave our psych patients Parkinson-type symptoms, and we gave them benztropine to take care of those EPS symptoms? Well, it's the same shit, different day. This is actual Parkinson's. So we're giving them an anticholinergic to help them. But you got to be careful. I already warned you. Now, you don't like your license and tired of being a nurse. Well, you go ahead on and give it to these people that I told you not to give it to. And I see your ass in court. Maybe I put some money on your books. I don't know. Anyway, moving on. The number one drug that these patients are usually always on is the actual Parkinson's medication itself. Levodopa, carbidopa. Now, if you forgot, like if you literally forgot what I taught you in part 1 Parkinson's video, here's a little refresher. Remember that Parkinson's is as simple as a dopamine acetylcholine imbalance. Specifically, dopamine is low. Levodopa, carbidopa, Sinemet is literally converted into dopamine in your brain. They take this drug in your brain, your body takes this drug in your brain and converts it to dopamine. It don't get no better than that, but you gotta know a lot of shit about it. So here we go. Usually it's titrated. The physician or nurse practitioner is gonna start off low and then go up. And it takes a few weeks to work. You can't be promising your patient a rose garden on Monday and the day is Saturday. No, they ain't gonna work good. They ain't gonna work good at all. So it is going to take a few weeks to, reach its effect. It treats the tremors and the bradykinias, but it don't do shit for them cognitive changes in memory. I'm gonna say that again. It treats the tremors and the bradykinias, but it does not do a damn thing for cognition changes or memory. Don't miss that point. Never stop this drug abruptly, and this medication can turn the bodily fluids dark. Okay, not just your pee-pee, not just urine, no, sweat, tears, saliva can be black, brown, or red. Oh my God, like that would fuck you up if you like thought your patient was peeing blood and shit. Well, you might want to check their med list. You feeling me on that? Okay, now we're going on now because I'm kind of tired of shit. I've been taping all day, shit. So here we go. Stay with your girl. The next one is entacapone, also called brand name Comptan. I have seen this and I have given this drug to patients. And matter of fact, I ain't gonna lie to you, I done gave all this shit to patients. But here we go with this one. Why are we on this particular medication? You are not ever taking this by itself. You are giving it with levodopa to decrease, get this, the drug tolerance. Here's what I'm saying about drug tolerance, because you know, sometimes drug toxicity, drug tolerance, drug dependence gets very confused. Drug tolerance means the longer you are on the medication, the less that motherfucker want to work. Literally, you've been on it for years and you built up a tolerance for it. Same thing happens with nitro. That's why we have a nitro-free period of 12 hours overnight. This can happen here. The patient can build up a tolerance. And let me just say for the record, if they were to build up a tolerance, that would present itself as psychosis, hallucinations, delusions, cognitive crap. Okay, so you know, this tolerance is real. So taking this medication will allow the patient to be on levodopa, carbidopa for a long time without building up this tolerance. Also, this medication is thought to potentiate the levodopa and make it, you know, worth its while. Okay, going on now, moving. Number 5 medication is real stupid important. And what is it? Rasagiline or selegiline. This shit sound a lot alike. They're not the same drug. They're different drugs, but they all end in geline. They are MAOIs. You know about them MAOIs because I told y'all to master in psych and psych meds first. And if you did like I told you, you know that this medication can be combined with shit. Look, don't take with levodopa. Might want to put a star by that in your notes. Low tyramine foods. So this patient ain't doing no deli. They ain't over there in them in that beer. They're not over there chilling with pepperoni. They're not doing a bunch of cheeses. They're not doing pickled nothing. They ain't playing in no soy sauce at the Chinese restaurant. You remember low tyramine foods. No MSG and all the rest that go with it. And this does help the patient in the early stages. So the deal is, I just told you, the longer you on levodopa, the more likely you're gonna become tolerant. Shit ain't gonna work after a while. So what do we do in the early stages? We try some other medications, or perhaps we come over here and try amantadine or benztropine in the early stages, trying to make it last so that we don't have to switch up to levodopa until we absolutely have to switch up to levodopa. Okay, now, notice what I said about all this shit. Everything that I gave you so far is working on this dyskinesias, tremors, bradykinesia. I keep saying it. I don't know if you heard me. None of this shit works on cognitive changes in memory. So the patient very often will be given, here we go, the patient very often will be given either ribostigmine or donazepam or ribostigmine. These two medications are super popular. Donazepam is your Aricept. You done gave that out so much you can't even think straight. Ribostigmine is your Exelon patches. Both of these medications are extremely common in the care of the patient with Alzheimer's. This is being given for memory improvement and improvement of cognition. That's what's going down in Chinatown. Now, I want you to help me out here. You remember I said we're doing clinical judgment. I gave you some take action tips, and that was your medications. If we move on over here to number 6, evaluate outcomes, stay with me because it's going to be a little jump. If these medications don't work based on your evaluating the outcomes of what they should have did for the patient, then number 6 of the clinical judgment model comes into play, where the nurse is explaining that none of this is working anymore, and the patient may have what we call a last resort with surgical treatment. One of the surgical treatments I want you to take a look at, because like I told you when I first started, season 1, episode 6 of Grey's Anatomy on Netflix literally has a patient on there. In fact, a white male over 60, which I told you was the profile of this patient's, this disease process, and he's getting DBS. What is DBS? This last resort surgical treatment, DBS, direct brain stimulation, is where when you put this electrodes in this patient's brain and you have like a little generator, a battery pack generator, put in your body like a pacemaker and send stimulation or signals, you know, electrical signals to the brain, because the leads are in the brain. When they put this in this patient's brain and they send those impulses to the brain from this little battery pack here, like a little pacemaker or whatever, generator, it decreases involuntary movements, improves the patient's gait or walking, decreases the tremors, and get this, decreases the need for levodopa, which will decrease the dyskinesias, which come from levodopa. The longer you're on it, the more you're going to use it. So that would be an example of exercising number 6 of the clinical judgment. You've evaluated the outcomes. You're sharing with the team how none of this shit is working. Could he possibly be a candidate for DBS? The patient in the Grey's Anatomy is a very good example of a patient who did well with it. And then part of your evaluating outcomes is always monitoring for either drug tolerance or drug toxicity. When a patient becomes toxic on these medications or there's an overdose, the dyskinesias are severe. When the patient develops a tolerance to the drug, the cognitive, memory, behavioral, psychosis, hallucinations, delusions pop out. When you are evaluating the outcomes of this patient's care, you are also monitoring for orthostatic hypotension and their respiratory status, because I told you they died from respiratory failure. So you're making sure that you're checking the vital signs, the SpO2, however often that you need to do that. Not very often, but you know, at least every 4 to 8 hours, right? And then you're also analyzing the family. Don't forget the family with these patients and the Alzheimer's patients. Not only is there a great potential for abuse, but there is a great need for you to love on this family and offer them some alternatives of care. Most people, especially the ones I talk to, they don't understand that there's something called respite care, and that is a program that insurance pays for, where the family that's trying their best to love on their family and take care of them and not put them in a home can get a break for vacations or work-related breaks, or even just weekend breaks. They can get this break from taking care of their family by putting them in a long what we call an assisted living center, or even a skilled nursing facility for a weekend, for a week or two while they go on vacation. And so that they don't have to worry about them and they're getting excellent care. And then when they come back from their vacation, they pick their mom up or their dad up and they go back home. Insurance pays for this. Very few people take advantage of it though. That's sad. There's a potential for abuse. I'm just saying, people get fed up, and these people might have some cognitive issues where they're paranoid, they're hallucinating, delusions. I know the one person I know said that their family member was screaming in the middle of the night. That's awful. Now, lastly, in the evaluation of the outcomes, this patient is an excellent patient for home care. maybe a sniff, but I kind of steer away from that just because I wouldn't put my family in a nursing facility if I could avoid it. That's why I tell y'all to put your 15% of your income away in a freaking 401k that you working at the job anyway. You can put the shit away so you can afford to buy the best for your family. But home care, remember palliative care. Remember, this patient at the end will need assistance with all ADLs. And so that's part of what we do. We do case management, basically. Now, I always promise, and sometimes I forget, so y'all gotta forgive me, but I got it today, y'all. As I end part 3 of this Parkinson's video, let me give you a little love, because I told you before that I always give you guys a complimentary study guide with diets, nutrition, prioritization, delegation, who you see first, who you don't see first, float nurses, what else is in here? Your disease processes, your select alls on neutropenic precautions, bleeding precautions, seizure precautions, all your shots, hypovolemic, septic, and otherwise. I've got all your labs in here, even though this test gives you normals. I mean, I got everything you ever needed. So, you know, call me. Let me help you know how to reach out to me. All you gotta do to get your free complimentary copy of the Oh My God packet is either email me or text me. Now, my daughter was fussing at me the other day. She's like, you told him to call you. Because she know, and I know, and you know, I ain't answering that damn call. I don't even answer my kids' calls. She's probably thinking of that. But I will text you all the time. So you text me. I got you. We can make this happen. And, yeah. Bye. I'm sorry. This is, you know, bye.